Srikanth? Hello, Srikanth.
Sir.
Yeah, the needle placement, tip of the needle is important for IV in central line cannulation. We will sharpening of the length is more, but you will see the half of the needle. Without that needle is still need to pass forward, but already it is passed. So the chances of puncturing the unnecessary structures like lung, అది కొంచెం highlight చేయి.
Sure, sir. అన్నీ ఉంటాయి.
అదే దిస్ ఇన్సిడెంట్స్ హ్యాపెండ్. మనం నీళ్ళు ఎక్కడో ముందు ఉంది అనుకుంటాం, అది ఆల్రెడీ బియాండ్ దట్.
కామన్ సార్, అంటే బ్లాక్స్ లో కూడా మనకి ఫెయిల్యూర్ కి కామన్ రీజన్ అదే సార్.
అది బ్లాక్స్ ప్లస్ లైన్స్ పట్ల సబ్క్లేవెన్ దగ్గర కానీ మాత్రం మిస్ అయ్యామంటే ఇట్ విల్ కదా.
అవును సార్, అవునవును.
ఇది ఇన్సిడెంట్స్ హ్యాపెండ్ దట్ pneumothorax.
స్క్రీన్ విజిబుల్ కదా సార్? ఫుల్ స్క్రీన్ వస్తుంది?
Yeah, it is visible.
మరి మోహన్ నిద్ర నైట్ డ్యూటీ చేసి డైరెక్ట్ గా వచ్చాను సార్. అనమాట. మీరు చెప్పినప్పుడు కూడా మంచి టైట్ ప్యాకెట్ షెడ్యూల్ లో ఐసీయూ ఫుల్ గా ఉంది, ఒక 4 వెంటిలేటర్ కేసులు ఉన్నాయి. సో హడావిడిలోనే మళ్ళీ ఒకసారి రివైజ్ చేసుకున్నాను. అప్పుడు ముందు చెప్పిందే కానీ ఒకసారి మళ్ళీ చెప్పే ముందు ఒకసారి చూసుకోవాలి. ఇది సమీర్ నోరోజే అని బుక్ ఉంటుంది సార్, షేర్ చేస్తాను. చాలా బాగుంటది సార్. అల్ట్రాసౌండ్ యాక్చువల్ గా ఎవరికైనా సీరియస్ గా ఇంట్రెస్ట్ ఉండి రెగ్యులర్ చదువుదాం అంటే
అది అందరికీ కావాలి. అండ్ క్రిటికల్ కేర్ ప్రాక్టీస్ నౌడేస్ ఇట్ ఇస్ బికమ్ మ్యాండేటరీ.
చాలా మంచి టెక్స్ట్ బుక్ సార్ అది, సమీర్ నోరోజే అని. అల్ట్రాసౌండ్ అంటే యాక్చువల్లీ మనం మామూలుగా ఇప్పుడు స్పెసిఫిక్ గా ఒక టాపిక్ మీద కానీ దేని మీద అంటే ఆర్టికల్స్ ఇప్పుడు చదివేయడం ఈజీ, కానీ టెక్స్ట్ బుక్ చదవాలంటే మళ్ళీ మనం ఎస్పెషల్ అంటే యంగ్స్టర్స్ కి మొన్నే పాస్అవుట్ అయ్యి వచ్చిన వాళ్ళకి కొంచెం ఇంట్రెస్ట్ ఉంటుంది, కానీ ఒక 10 years అలా ఉన్నప్పుడు కొంచెం కష్టం అవుతుంది సార్ మనకు. కానీ సీరియస్లీ ఇంట్రెస్టింగ్ సార్, గ్రిప్పింగ్ గా ఉంటుంది మొత్తం అంతా. ద వే హీ రైట్స్ అబౌట్ ఆల్ ద టెక్నిక్స్ అండ్ ఆల్ చాలా బాగుంటది అది. సమీర్ నోరోజే పీడిఎఫ్ కూడా ఉన్నట్టు ఉంది సార్, నేను షేర్ చేస్తాను. షూర్ సార్.
గుడ్ మార్నింగ్ సార్ డేవిడ్ గారు. గుడ్ మార్నింగ్ శ్రీకాంత్.
గుడ్ మార్నింగ్.
తెల్లవారిపోయింది లక్ష్మీవారం. శ్రీకాంత్ ఎలా ఉన్నారు? బిజీ మళ్ళీ అంతా పీక్ డెంగ్యూ మలేరియాలు వస్తున్నాయి, వైరల్ ఫీవర్స్.
సార్ అసలు చాలా రోజుల తర్వాత వెరీ క్లాసికల్ కేస్ ఆఫ్ ఫాల్సిపారం మలేరియా సార్. అసలు కనబడుతున్నాయండి బయట తీసుకురావడానికి. ప్రస్తుతానికి ఏదో ఇవాళకి ట్రెకోస్టమీ చేయించాము. పెరిఫరల్ స్మియర్ లో కూడా గ్యామటోసైట్స్ అసలు అబ్బా అంతా ఈ మధ్యకాలంలో చూడలేదు ఇంత స్ట్రాంగ్ ఫాల్సిపారం మలేరియా సెరిబ్రల్ది. ఆయనకి అప్పటికి సంతోష్ కుమార్ సార్ ఫిజిషియన్ ఉన్న సార్కి డౌట్ వచ్చి, నిజంగానే మలేరియా అంటావా ఎంత సివియర్ మళ్ళీ అని పెరిఫరల్ స్మియర్ డబుల్ చెక్ చేయించాం, కానీ ఇంప్రూవ్ అవుతున్నాడు సార్. బట్ ఇట్ లుక్ లైక్ బాగా ఏఆర్ఎఫ్ లో ఆల్మోస్ట్ గ్యాస్పింగ్ లో తెచ్చారు సార్ మన దగ్గరికి.
చేస్తున్నారా
సార్?
డయాలసిస్
అవుతుంది సార్. యాక్చువల్ గా 4 sessions అయ్యాయి సార్ ఇప్పటికి. బాగా అంటే వచ్చినప్పుడే బాగా బ్యాడ్ షేప్ లో గ్యాస్పింగ్ లో వచ్చాడు సార్. అసలు ఆ రోజే ట్రెకోస్టమీ చేయించాం, సెన్సోరియం బాగుంది, నిన్నంతా సపోర్ట్ బాగానే టాలరేట్ చేశాడు సార్. ఇవాళ ఆల్టర్నేట్ 2 hours సపోర్ట్ 1 hour టీపీస్ మీద పెట్టి అవుట్పుట్ స్టార్ట్ అయింది. బట్ స్టిల్ వీఆర్ గోయింగ్ ఆన్ విత్ హెమోడయాలసిస్ సార్. క్రియాటినిన్ అలా ఫిక్స్ అయిపోయింది 6 odd లోనే. బట్ స్లోలీ మేకింగ్ ప్రోగ్రెస్.
Okay, so
we'll start sir or
yeah, we'll start. Mohan sir kuda vachinattunnaru kada. Good morning sir. Yeah, we will start.
Morning, sir.
Yeah, good morning all. Today
మలేరియా అంటే అదే చెప్తుంటే అడుగుతున్నాను అనేది వినలేదు.
today Dr. Srikanth, consultant anesthesia and critical care, ABC Hospital Visakhapatnam, is going to talk on improving needle visibility in ultrasound. Actually, it is looks simple, but it's very important in ICU and both in anesthesia practice. So that sometimes we are misguide the needle tip, thinking that the needle is somewhere. We are visualizing the needle, but it is more forward. It is already touching the dangerous, puncturing the dangerous structures like lung and other vital organs. So the visibility of the tip of the needle is very important to prevent the life-threatening complications. In that aspect, I request Dr. Srikanth to enlighten this topic so that it's very useful in practice of anesthesia and critical care settings. Thank you, Srikanth. Please go ahead.
Thank you so much, sir. Good morning, everyone. Today we'll be talking about improving needle visibility in ultrasound. First of all, let's think what is the problem we face, why the need of this topic basically for discussion. So we at least now at least in the group of 30 to 40 people we are having in Morton, at least 10 to 12 people will be very much like pro in ultrasound, at least not pro, but at least they're doing regularly ultrasound guided procedures and they're well versed with all that. But in any group of consultants, we see at least 50% of the people struggle with ultrasound, or they think they're doing it right, but sometimes they may land up in complications. So when we go in this training programs, the screen is visible, sir? It's moving now?
Yeah, it's moving. Carry on.
Thank you, sir. So this is UZIP training. UZIP abbreviates to ultrasound guided interventional procedures, whether it can be in anesthesia, whether it can be in critical care, where we are placing lines and ultrasound guidance, and also nowadays we are ultrasound guided interventional procedures, sir.
Right.
We are going with regional anesthesia techniques for analgesia and ICU, which is gaining very popularity. Or we are using ultrasound guided in pain. In pain also, fluoroscopy used to rule for so many decades, but now slowly even the senior pain physicians, they are shifting their focus more and more to ultrasound. So ultrasound is already playing a major role in all the three fields we are handling, and also it will be even much, it will occupy much bigger space in the coming phases. So when we go to a UCIP training or ultrasound guided workshops in our conferences of anesthesia and critical care, whenever we go that 1 day or 2 days like that, we'll feel like we got everything, how wonderfully they're describing and all. We will see beautiful hyperechoic pictures of needles and all. And okay, we will catch our train or flight back to our home place, and we get ultrasound machine, we get the needle, and we start doing the procedure. Then again, the first thing which comes, where is the needle? Where is the needle tip? So is the correct plane we are scanning? So what's the difference? So how good it is in the 2 days of our workshop, and how bad it is at least for a few of us when we are starting the ultrasound at our own setup in our hospital for either for anesthesia or critical care. The thing is, there is a clear-cut difference in quality of the machine at least in some places. So for the workshops and all, they will use the best possible machines available in that center for sure, and the training will be by the best minds in the team. Also, you will have most of the times you will have a very little time to practice in the workshops based on the number. So again, some other friend, your friend will, or 2 or 3 members in the back, while you're doing, they will say that, there is the needle. Yeah, your tip is like that, like top students in the batch. So you will feel like, okay, I'm not able to see, fine, it's there somewhere, and you just drop it out of inferiority complex and you move on. So this is what regularly happens in workshops. So a sincere suggestion is, whenever you come back, especially you come back from a workshop and all, you identify a local person in your hospital or in your town who is doing a good volume of ultrasound guided procedures, and go to him out of your duty times. You can be with him and learn from him. So there you get a lot of time to understand what's going wrong and all. So now coming back to the UCIP training, so these 4 components, if you're planning to do an ultrasound workshop, you have to categorize into these 4 and give lectures or make them understand these 4. Understanding the device operations. First thing is visualization of needle insertion and the injection, which is the more important things. And then you have to understand each device separately, just like how we understand our anesthesia machines. You have to understand each ultrasound machine, what are all the features it have, any advanced image interpretation modes it have, and all. And then image optimization, how good you can make it better, like increasing the gain or depth or time gain compensation. You're able to focus the object you want to see and all. And then image interpretation, which is very important. So what you see is the thing you want to see. That's a lot of times we go wrong, like we will mistake some other thing or artifact for a nerve bundle and all. So image interpretation is also carries equal role. So for the training part, we can use various phantoms like that. First one on your left is a simple water bath phantom. So all these phantom models are training whenever you go on. So I'm not going into details of basics of ultrasound, how they work and all. That will be completely a different class. But whenever you focus a needle or a structure, so the main thing that is very important is the acoustic impedance. I mean, we know that the beam goes and hits some structure and comes back. Based on that, we will have the image. The bigger the acoustic impedance difference between 2 structures, the better your target will be visible. So, which is why needle, which has a very high acoustic impedance, I mean a metal object, will give a very clear picture in a water bath. Then this same brightness will not be visible when you do in a human case, like on a case when you're planning an intervention. But these training programs actually guide you to the path of the needle, how you can insert, what is the visibility you will get and all. So there are low fidelity, I mean, or in other words, low quality phantoms and high quality phantoms. These water bath tofu is just like a cheesecake like model, sort one, or these gel pads what we have, these are all low fidelity or low quality phantoms, but easily available, and we can train people very easily using these phantoms because they are very easily available and cheap. So these are moderate ones where they will like insert some plastic tubes into the gel phantom, which can mimic vessels and all, so that you can get some real-time training like that. So the right one is the needle cervical spine model inserted in water, and then you do ultrasound. Or these are various levels of training of ultrasound you get in training programs. So this is a high fidelity or human cadaver ultrasound workshops are considered high fidelity, and these machines, apart from that, this is a UGRASP phantom, where ultrasound guided regional anesthesia stimulation phantom, the abbreviation for that. So this is a high fidelity ultrasound simulator which allows documentation of trainee performance and the needle positioning during simulated procedure. So In addition, it provides the trainee with the immediate feedback. It runs on the feedback loop system. So light and sound indicators will be there where you're going wrong. It will indicate and all so that you can correct them. And this is another high fidelity one, eJuno. This carries on real time and image interpretation support system. This device allows the operator to use a bank of stored preset images and video and anatomical cross sections, which are already there is a data in the machine, and that data can be used during the procedure of choice to provide real-time on-band high-quality reference and image interpretation support. So these two and many more are considered as high-fidelity trainings or high-quality training programs. And this is another one where we combine ultrasound and fluoroscopic phantom for cervical transforaminal, but it can be applied to the wider fields actually. So the phantom contains anatomically filled arteries and all that exhibits the pulsed flow under ultrasound Doppler examination. These are very high quality trainings and obviously they come at a cost. So the most important whatever we learn is mainly that manual dexterity or how you operate the ultrasound probe and the needle orientation. So this you can easily do at your center whenever you are free. Your cases are done at all. You take a gel pad and all these directions which are given, you can just rotate the knob like that and see what is going wrong with few directions and what is going correctly with few directions, where you can get the exact image of the needle and all. So how you hold a probe also carries a very important. So the extreme left one is the correct way to hold a probe, where few fingers, this is called a freehand technique, which we'll be discussing in one of the slides forward. So freehand technique where few fingers are used to actually support that exact area so that the probe doesn't slip away. So we have basically two planes, in plane and out of plane. Most of us know in plane where you insert and inject the needle, you pass the needle along the probe direction of the long axis of the probe, where you can see entire needle length in the in-plane technique. And out of plane technique, which we commonly use for our vascular procedures in our ICUs, where the tip of the needle is visible in the out of plane technique. Firstly, coming to out of plane technique, which is commonly we do in ICU for vascular techniques. So what is this wheeled thing going on? So if you see the left extreme left one, so the white and a dark image of probe is there. So whenever you're trying to understand what's going wrong with needle visibility, the very important thing you have to keep in mind is the beam of ultrasound which comes down is hardly 1 mm in diameter. So even if you maneuver a little bit like 10 degrees, 15 degrees like that, there is a very high possibility that you may lose the needle or at least the needle tip. So that you have to keep in mind. And this what's happening over here. So when you see probe in the black, if you identify, what you will get in the ultrasound picture. Hope you're getting my speed and all with this. You're comfortable, or I'm going too fast?
Okay, Srikanth.
Okay, right, sir. Okay, so in the extreme left one, so when you place, you imagine your the dark one is where your ultrasound probe is there, and needle is like that. So what you will see that exact that forget about the entire needle and all. So you only focus on that vertical line and what you are seeing there. So what you will see there, you will feel like it is the tip of the needle. So that is the most common error which we do at least early in the practice. So what you think your needle tip is there and your target structure is the bottom dot in the rectangular bar. and you think that you're still that far away, and you go deep or you change the ultrasound position. These are the two things which may land up in difficulty. And if this is applied in a different scenario, if you feel that the tip is the target area is there, so you think that you are exactly on the spot or on the near the vein or so, but actually the tip is little bit far away. When you're doing a jugular or a subclavian, with this you have a very high chance that you're hitting the lung. So this thing has to be kept in mind. So always right from insertion, you have to see the tip. And it's not like you insert to some extent and then you bring in your, okay, I'm not able to get the line. And this most commonly when this scenario arises, even most of the times when we do right from starting ultrasound probe, if you keep things go on well. But sometimes what we do, actually, okay, this is a simple and easy case, young fellow, thin fellow, we will do on with the landmark guided one. And we start, and after 2-3 maneuverings or manipulations, we don't get the jugular vein. And then we ask the assistant for the ultrasound probe to be kept. So then when you keep, you feel that that is the tip, but actually the tip is far away. So we have to keep in mind that whenever you feel like that is the tip, you just draw away like that. So like along the same plane, you just track it down. If the tip is still visible or if it is not visible. So if it is not visible, then you're fine that the initial one, what you have seen is the tip. But always you have to track down on the same line. Don't change the direction, just on the same perpendicular line, you track down the neck always to ensure that your tip is in the right place. So also the next problem we face of not visualizing the tip, the right one is the angle of insertion. When we go very parallel to the probe, I mean like complete transducer line, so the possibility of just use some pointer. So when you go like in this angle, what you see, so you are going almost parallel to the probe. So you are going like that. So you are going deep and deep, like you will be thinking that actually there is no image on ultrasound. So you push further deeper. So what you see here, you're actually hitting, consider this as jugular vein. You're actually onto the vein. But what you see nothing. You see nothing because the angle of insertion is wrong. So it is almost parallel to the plane. So the ultrasound beam will be coming like this and going like this. So it will be just showing the jugular vein, but your needle will not be seen. So what you do, you will push it further down. So thinking that the needle is not visible. So you will land up in puncturing the lung. So this is another common mistake what we do. So always you have to keep an angle, keeping in mind of the ultrasound beam. Always whenever you are doing, so you have to keep in mind how the beam goes. So this you can see the perfect picture where with an angle, a less acute angle, it's going less steep angle. You have to always measure to the skin, not to the probe. Skin, it's very angle is very acute. So less acute angle you do, and here the beam is beautifully hitting your needle. You are able to see the tip and you are able to see the jugular vein and you are spot on target. So these two are the common things, common mistakes we do generally, at least in the initial part while we are doing. So in the coming slides, we will discuss further how to enhance the image and all to not to repeat mistakes. And this second problem where that angle, to the loss of angle, if you are unable to see the needle, so you can do a slight tilting of the ultrasound transducer in different positions to see exactly where the needle is, if you are not able to visualize the needle after few passes into the skin. So coming to the in-plane one where the needle traverses the length of the beam. So these are the different angles. It's the same again. So you see here the extent of reflection and all, how it's going on. So always in plane, most of the experts say you go as perpendicular to the plane as possible. Like this should be a 90 degrees. 90 degrees is the most ideal scenario where you get the perfect image of the needle. But what will you do using the 90 degrees one? More or less, it's for a subclavian block, it works very well because almost we'll be going in a parallel way like that. But most of the time, even sometimes when you're confused about jugular line placement, because sometimes there will be very less space between the artery and vein. Also, you will be unable to differentiate based on the sizes or pulsations in different critical scenarios where we face. There, we sometimes, or at least I sometimes check in the long axis view also while placing the line to see whether we are correctly on the jugular line. So always this ideal scenario of 90 degrees is not possible, but the experts say we should go at least as as close to 90 degrees angle as possible to get the maximum picture of the needle. And again, this is the angle what we're talking about. So more angle to the skin, it will you can see the this is the needle, but it's visible as a very faint line here. When the angle is decreased to the skin, you can see the brightness of this needle in the downward picture. So this is again the same when we, this another important thing when we are doing in-plane needling. So in-plane needling, you always go close to the probe as possible to decrease the traversing length of the needle. So when you start from a very far off point like the right one, so most probably you may end up consuming all your needle, but you're not hitting the right structure over there. And then this heel-in maneuver, what we'll be talking about. So you're unable to see the needle properly, or in this way, only few of the ultrasound beams are hitting the needle. So this maneuver where you will, this is termed as heel-toe maneuver or heel-in maneuver, where you will direct the probe towards the needle, so that more of the ultrasound beams are hitting the needle, and you will get a more clearer picture. So this is how it's carried out. And again, when we do this, there is again a small problem. What is the problem? Especially when we are doing something on a convex surface like abdominal blocks or knee blocks for post TKR pains and all, will give knee joint blocks. They're like convex structures. So when you try to do this heel-to maneuver, there is a gap left here, so which will cause an artifact over ultrasound machine. So what you will do, there are two things you can two solutions. This is either you can fill the space with gel, or you can actually inject some local anesthetic over there to raise a wheel. So these are the two techniques preferred by the teachers to remove that artifact in that gap. So this is what we are talking about: gel standoff or wheel creation at the entry point. So this is another very very basic thing, but very important. First you do a scout scan. You see the probe position, which offers the best view of the target structure, and also where you can get an ample of space for the needle to pass through. And when you observe that in scout scan, you always mark the point, like where you have to enter the needle. So marking the point helps you, because sometimes when you face difficulty, you because of the gel and all, probe will be moving little bit movement. Also, you will lose the needle length. So marking the skin is a very simple one, but a very effective technique, especially for the newcomers. Then this is the freehand technique we were discussing when we are talking about the correct position of the hand holding the probe. So where by having the operator's ultrasound transducer hand function as both transducer stabilizer and for localizing and maintaining the target structure. So he will rest the remaining hands on the surrounding the probe and apply a slightly downward pressure so that the probe is fixed in that position, and also the other hand will be used to inject the needle and the drug. And a needle gauze, we all know, like a big needle will obviously have more surface area, it will have more reflection of the ultrasound beam, so it will be better visible. But again, there will be patient discomfort when you are using a bigger needle. The trauma it creates, post-procedure pain and all will be high with the bigger needle. You always take the call based on the scenario and the difficulty you anticipate in that particular patient and in that particular procedure. And also, this is another very simple technique and often overlooked is the direction of the bevel. So why the direction of the bevel is important? Because so bevel being a notched up one will reflect more. Like as you can see here, this curvature, what you are seeing over there, so it will reflect more obviously. So the tip is clearly visible. And when you go with bevel down, this tip, like you cannot see the difference. Can you see the difference here? So this area and this area practically looks the same in the ultrasound. So you exactly don't know where the tip is and you may have passed your target structure. So direction of the bevel when you're using needles, if you have a curved bevel, so you keep always upwards to have a better visualization of the tip. And whenever you're, in spite of doing all these, and you always have a doubt that whether you are exactly at the point, because for the jugular lines and all, you have a possibility of hitting the lung, and in abdominal blocks you have very high possibility of entering into peritoneum and injecting there, or worst case scenario damaging some internal organ. So these are the two techniques where you use some liquid to enhance the picture. So in the left one, this is called a hydrolocalization or technique, where you inject a few cc of distilled water or saline or anything, you can actually get a hypoechoic picture when you inject distilled water through that. So through that hypoechoic shadow what you are creating, because it is not you are doing real time and you know the picture, suddenly an hypoechoic shadow appears, there is your water going on. So in that hypoechoic, your because of the difference in acoustic impedance, your needle will be very brightly visible. You can see over here. So based on, because the surrounding structure soft tissue will be a little bit bright based on their reflection. But when you inject water, that area becomes very dark. So your needle tip is exactly, you can see where your needle tip is. This is hydrolocalization technique. And the second one is microbubble injection technique, where you will inject a few cc of agitated saline, which will produce a hyperechoic shadow. So the same, either you have to be visible there, either you have to become more dull or you have to become more bright. So dullness is due to water, hyperechoic shadow, brightness is due to agitated saline. So either of these two liquids you can use. So, and you have this Doppler you can always use for the needle visualization sometimes. And also Doppler is helpful. This is available in submission, and you can actually see vessels and all with the Doppler. So where exactly we are, the possibility of accidental puncture will be very much decreased with the use of Doppler in ultrasound. So coming to Okay, we have learned all how to localize to direction of bevel, size of needle, and in case of all the difficulties, we use the hydrolocalization and all. But even then, we face difficulties. So then came this concept of what can be done when we have to increase the needle. Either we have to get more experience in handling these things, either the operator has to be good, the needle has to be good, machine has to be good. These three things are the areas of improvement. So the research always focuses on focusing these things. Through trainings, the operator will be more experienced. Needles and machine, they can be done through technologies. So what is the earliest initial thing they have done? They have added more holes. So in the previous slide, we have seen the bevel will give a good hyperechoic shadow. So it's the same concept, creating more holes in the needle. So more holes in the needle, more reflection from the needle, and the better needle visibility. Again, what is the problem with the multiple holes we create? That's more serrations, more tissue trauma, more pain to the patient. Then came this, okay, this is going some wrong, or this is causing more discomfort to patient. So the next level of invention came in the rightward needle. What you're seeing in the golden color is the polymer encased needles, where the needles are coated with a polymer which will be bright hyperechoic, which will give a hyperechoic shadow in the ultrasound machine without actually causing much of tissue trauma. These echogenic needles are freely available in the market now, and they are definitely of better use. I mean, like, I have the practical experience of using them. So these are few needle guides where the left one is the mechanical needle guide, where there is a device to fix the probe and the needle in that direction, so that doing a scout scan, you can fix the needle guide, and so that the direction of displacement will be very less using this. And on the right one, you have using this infrared technologies optical needle guide, where again it will help in the correct needle path. So these next thing is, these are the things in machine part, machine advances. What we are seeing, spatial compounding, where in the same area of focus, as we have a limited area of focus, so there are methods to improve the imaging or reflections and all, like the name indicates, compounding effect. So we can get a better image. You can compare the left one and right one images over here. Next is beam steering. Just like this is similar to what we do manually with the heel toe. Heel toe, what we do, if the needle is not visible, we will turn the ultrasound probe towards the needle. So in this, the machine does that. So if you remember a 1990s movie, comedian Ali will be selling brush. You don't need to like move your brush, you just need to move your head, that brushing will be done. It's like the same thing. Like if you are not able to correctly do the heel to maneuver, this one in the modern machines is the beam steering, where it will identify the hyperechoic shadow, and we turn on, it will steer in that direction, so that the needle visibility will be more. Instead of the routine perpendicular direction the beams are going, the beam steering is on, it will turn towards the needle. So next comes this advanced ones like 3D ultrasound probe or 4D ultrasound probes, where they add an additional component to the dimensions. 3D, there instead of the regular 2D ones we are using, there will be XYZ axis, and also a real time. In 4D, it will give a more real time picture, just like when we are doing CT or MRI guided procedures. It will be the same with the ultrasound also, where you will get more better pictures. But all these are more under investigation, and they have to come into clinical applications. I mean, like at lesser cost they should come. It will take some time and all. So these are a few other recent advances where we have the machine technology improving. So we are using complex signal processing, broadband transducers, and increasing the scanner bandwidth, increasing ultrasound beam frequency. Earlier we used to have routinely we have this low frequency one, but the deeper structures 2 to 5 Hz and 5 to 13 is the linear for what we are using for the superficial. And there used to be 18 Hz frequency ultrasound transducer where it is used to see very superficial nerves and all. Now they're developing, or maybe they are in market already, 50 Hz frequency ultrasound transducer where it's commonly used in pediatrics. And also dual imaging technique where you combine, so all these days we are using the CM and ultrasound together, and nowadays the photoacoustic emission technology and ultrasound technology are using in combination, and automatic optimization techniques like there are more and more parameters added to the ultrasound machines to increase the time gain compensation and all, so that you can exactly focus the area which is deep inside. And also these are actually under research, at least by the time this book is published in 2015, with sonographic border detection with automatic color marking. They mark like yellow for nerves, brown for muscles, like that. So you can more easily identify what are all the structures present over there. And these are a few tips for what we do in regular day-to-day practice. Like, do you see anything wrong in this picture? Students can answer. We are coming to the end of session, so mostly it will be like 3 or 4 minutes more. So anyone can find anything wrong in this one? Or is she doing correctly? By the way, she's Dr. Harshita Surange, a pain physician from IPSC Delhi. She heads the academic division out there. Anyone can identify? Venkatkrishna, Apurva, the youngsters.
Sir, that screen is actually its opposite direction. It should be facing towards the side of the procedure.
Side of the procedure. Okay. Or in other words?
Actually, she is not seeing the screen in the first picture while inserting.
No. She's actually seeing the needle in the first picture and then screen in the second picture. So that's what commonly.
Sir, position of the examiner in relation to the patient and the ultrasound screen.
Wonderful, wonderful. That's the exact terminology what we are talking about in this picture. Position of the examiner, position of the patient, and position of the machine. All three, what Venkatkrishna said is actually correct, but Apurva gave the exact terminology for the image. So the position of the examiner, position of the patient, and position of the machine, all three should be in line as pointed out by Venkatkrishna. It should be on the same side, not on the opposite side. But if it is done if the machine is on the opposite side, it should be like this. So you are comfortable sitting on a chair in line with the patient, in line with the machine. You are very much in view of where your needle is going, where your probe is placed, and where your machine is there. And without moving head side to side like that, one time needle, one time machine like that, you can happily do the procedure, and it offers the best possible view of everything what you are handling there. And can someone say what's wrong or which image is right in this one? The left one or the right one?
Second one, sir.
Second one. Why?
Because stability of the hand, sir.
Stability of the hand. You can see the stability of the hand. Stability of the injecting hand or probe holding
Injecting hands.
hand? Injecting hand stability. Okay. In what way?
And probe also, sir. Probe hand and injecting hand, both hands should be stable, sir.
Okay. Okay. Stability of hand is a way of putting it, but the most common error we do with the left hand technique, sorry, not left hand technique, but left side image technique is when you are trying to inject in the sideways like that, what happens is this will happen. The left-hander will hook the needle to the right and the right-hander will hook the needle to the left. So in the second one, the right side, what you are seeing, she is holding perfectly in the middle in the needle, so that hand position of needle insertion perfectly in line with the probe doesn't usually allow to sway the needle to the dominant side. So this is the common error where in this way there is a very high probability of shifting your or missing your needle tip, and you assume the part of shaft which is visible as the needle tip, and you go wrong with hitting the wrong structure or not hitting the right structure. So always identify the dominant eye. So this is done actually on the concept that if you are doing it with one eye, like she was doing in the right image, you have to identify your dominant eye, and if you are using only that eye, the visual input to the brain will be more. So how to identify your dominant eye? You make a triangle, like a double triangle with both your hands, just like cinematically how we pose for the taking a pictures and all. So you play. Maybe I will just finish off this presentation and then I will show you when I'm visible more. So we'll discuss this part after the presentation. And again, true or false round, which one is correct image one, and which one is the wrong way of doing the thing, the left or the right?
Second one is correct, sir.
Second one is correct because
support is not there in first one, sir. Hand support.
Support is there.
Stability of the patient hand.
Okay. You are talking about only operator related issues. Assume. In the second one or the rightward image, you are able to see the needle, how it's going, whether it is going exactly in plane with the ultrasound probe and all. Whereas in the first image, you are just assuming you are going in the right plane by placing the needle under the probe. For the same patient, same side, you can do, these are all very small variations in the how we do procedure, where we get a better, clearer image and also reduces the operating or runtime errors. So in this right side image, you are able to see where your needle is going exactly. So just like surgeons are asked to see the tip of the scissors, where they are going with the scissors, so that they don't cut any, I mean, like other than the intended structure. So this is the same way in the second one or the right side image, you know exactly where your needle is going in the right path or not. So also when you, this is the, like when you get the right one, again, you have to change the needles, especially this is for the anesthesia part, for the blocks and all also, but also nowadays in critical care, we are going with the regional analgesia techniques. So always you have to apply the clamp to remove the needle at the part of needle covered by plastic, the initial part, not on the needle, it will slip away most of the times. And complete plastic portion also, you don't cut that, because there is a very high chance of puncturing the cap and all. So the tips: be ambidextrous, like Rajnikant in movies, he will be signing with both the hands and all. So be ambidextrous, improve your left hand too if you're a right-hander, so that it will hold the probe in a better way. Hold your transducer and needle as a pen, anchor your probe hand, study your injecting hand, apply very little pressure, move one hand at a time. So this particular point is very important. Move one hand at a time, not mess with both the hands at the same time. You juggle both and then target for ideal image. So in incline approach, be as much parallel to the probe as possible. And the most important golden rule is don't see the needle, don't advance. So the source of images, this is a wonderful book. I suggest to all, even the consultants who are using ultrasound also. Samir Naroje's book of ultrasound, Atlas of Ultrasound Guided Procedures, is a very wonderful book for ultrasound, and it's explained in a very simple way and with very gripping chapters and all. So I got 6 months IPSC training, and those images are the courtesy of IPSC training on there. So thank you. And that dominant eye we are talking about. I think now you are able to see me. So this is how we identify the dominant area. Like movies like picture, we will see like this, no? So we will make like this, and we will focus on a distant object like a wall clock, like that. So you will center it in this space, the wall clock, and then you close one eye and see whether you are able to see clearly with the other eye. So you close your left eye and see with the right eye. If the image is perfectly in the center, even with the single eye, initially you fitted that object with both eyes open. When you close one eye and you're able to see the image with one eye in exactly center, it is your dominant eye. If that image moves away from your so-called that gap, then it's not your dominant eye. So doing procedures with using only the single eye will actually give a better picture, because it increases the visual input to the brain. So that is the concept of identifying the dominant eye and using it for procedures when you are facing difficulties. When you're able to wonderfully perform with both your eyes, there is absolutely no problem. And thank you so much for the patient hearing. It's been a long session. Thank you.
Thank you, Srikanth. Such a nice presentation. I think, do you have videos of same thing, what you are doing, the procedure, either lines or blocks? You have videos how best you are seeing the tip and how you are manipulating the probe.
I will make them, sir.
Yeah. And also we better to have one ultrasound workshop along with you and from our side, from Medicover and Care Hospital.
Yes, sir. There are few who are doing wonderful work. Sarath does very good ultrasound blocks as far as I know, and Omkar is one who uses ultrasound. Venkat Krishna is a teacher in ultrasound who is KJ chest and professors are doing. There are few people, at least in whom I know, they are doing very good ultrasound guided blocks. I'm using more in critical care now, but anesthesia part and also they do very well. So with these few people, Kiran is another on Rajam. So few of us make that program, so for the DNBs and all, it will be nice.
Srikanth, automatic గా మూవ్ అవ్వకుండా అదే సినిమా లాగా వెళ్తుంది అన్న ప్రోబ్ ఏంటిది? I didn't get it.
సార్ అది బీమ్ స్టీరింగ్ సార్. బీమ్ స్టీరింగ్ అంటే ఏం లేదు, that heel to maneuver what we do now, sir. So actually if the needle is not in the line, so we'll just slightly tilt our heel in maneuver under. We will tilt the probe like that to see the needle, so that more of the needle surface area will be reflected back to the machine. But beam steering technology uses the same concept, sir, in the machine. So it will actually, if you are not able to see if we turn on the beam steering, the beam small, the ultrasound machine, they fall perpendicular, vertical beams of spray. So in the beam steering, they will go like this, sir, slantly, if we on that feature, so that more needle surface area will come into view for the better visualization of needle. మాయలో సినిమాలోని బ్రష్ అమ్ముతూ ఈ బ్రష్ మీరు చెప్పక్కర్లేదు, తల తిప్పితే చాలు. అదే
అంటే అలా కాదు, నేను అడిగేది ఏంటంటే ఈజ్ ఇట్ ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ వల్ల ఏమైనా అవుతుందా, మనం చేయాలని అంతే, అంతకంటే లేదు.
it happens, sir. I mean, like there is a feature in the mission. All these wonderful innovations are coming in ultrasound, sir. Hopefully, we'll see all of them in near future.
AI included.
Yes, sir. Satish, sir.
Suresh wants to ask question. Suresh. Satish Kumar Tamiraju. Na?
శ్రీకాంత్,
Sir, good morning.
గుడ్ మార్నింగ్. ఇది మనం నీ రీప్లేస్మెంట్ కట్స్ ఎంత తీసుకోవాలి, అది పర్ఫెక్ట్ గా యాంగులేషన్స్ అందు కూడా ఇప్పుడు నావిగేషన్ లో ఉన్నాయి కదా, అట్లాగే మనకు కూడా ఏమైనా బీమ్ ఒకసారి ఐడెంటిఫై చేసుకున్న తర్వాత ఎంత యాంగిల్లో ఎంత డెప్త్ లో వెళ్తే మనకి ఆ వెజల్ లో లేకపోతే నెర్వ్ తగులుతుంది అన్నది ఏమైనా ఇన్ ఫ్యూచర్ కానీ ఎక్కడైనా జరుగుతున్నాయి ఇలాంటివి?
Exactly, I didn't get your question. Ante identification of the ante scouts
procedure
yeah,
is
depth with avani.
Procedure is being supported by artificial intelligence, or else what we call it is, example is knee replacement lo navigation technique lo enta ఇవ్వాలి, ఎంత ఫిబ్యులర్ కాదే ఫీమర్ కట్ ఎంత ఇవ్వాలి అన్నది క్లియర్ కట్ గా వాళ్ళు ఒకసారి ఇమేజ్ తీసుకున్నాక ఆ ఇమేజ్ మీద క్యాలిక్యులేషన్స్ చేసి ఎంత డెప్త్ వెళ్ళాలి, ఎంత యాంగిల్ లో కట్ చేయాలన్నదంతా మెషిన్ చెప్పేస్తుంది మనకి.
అవును సార్, అవును అవును.
ఇక్కడ కూడా ఒకసారి ఇమేజ్ ని మనం ఫ్రేమ్ లోకి తెచ్చుకున్నాక మనం ఎంత డిస్టెన్స్ లో ఉన్నాము, ఎంత యాంగిల్ లో వెళ్ళాలి, అవన్నీ కన్నా తెలిస్తే ఇట్ ఈస్ ఈజీ అవుతుందేమో. ఏమైనా అలాంటివి ఉన్నాయా?
అంటే ఎగ్జాక్ట్ యాంగులేషన్ అని కాదు సార్, దీస్ ఆర్ ఆల్ లైక్ దీస్ ఇంప్రూవింగ్ టెక్నాలజీస్ అండ్ ఆల్. టైమ్ గెయిన్ కాంపెన్సేషన్ ఇస్ వన్ థింగ్ సార్. So where you can exactly focus on the deeper structures, like in the thigh, middle of the thigh, if you are going for a sciatic nerve block. So like linear probe, obviously you have to place that convex probe because of the depth of the structure. So previously under with the regular stuff what we have, actually sciatic nerve is a very hyperechoic structure, కాబట్టి it's easily visible. Sometimes you may not actually see that clearly. So this time gain compensation feature on the ultrasound actually helps you to focus on that particular area where that particular area will be more visible, sir, carrying the target structure. We can actually do a scout scan and then identify the area and use TGC to actually highlight that area. Also this latest image photoacoustic in combination with ultrasound, and also this color marking, sonographic border detection is what they call. So color marking, this will come in future. They're saying like where you can actually mark color marking, like just what you get in Doppler, you can actually color the yellow, nerves will be colored yellow, muscles will be colored brown, like that, red and yellow for the blue for the veins and arteries, so that it will make your job very easy. And also this 3D and 4D ultrasound probes exactly work on the concept you have just asked, sir. So they will provide a real-time feedback on what you are actually asking, and they will give the feedback to us, so that where that intended structure is there. 3D and 4D ultrasound probes are maybe they're very costly, but the concept is the same.
Thank you.
Yeah, Srikanth.
Sir.
If you make a marking at exactly where you are putting the probe and direction and tilt, then you calculate the depth and the length and the direction.
Yes.
So once you calculate this one, like this much centimeters,
yes,
but the needle 1 mm is equal to like 1 centimeters in the structure. No, it is not exactly the length is equal to the length of the needle.
Not like this.
It over calculate or it under calculate.
But more or less we will get a very fair idea, sir. So I will tell you a very practical example what I have seen in once we are trying to, I mean, like trying to do empyema aspirations, a pus pocket aspiration in the lung. So morning duty, some someone is there. I'm not going to name them. Madam is actually in some other place. She has shown the ultrasound and told to drain the pus pocket, and she went away. So I was actually doing. I was in OT attending some case, and the consultant who is doing in the ICU is facing some difficulty. So I was called down, sir, Sudandi, we are able to visualize that thing, but we are unable to get the aspirate, and we are unable to identify the needle exact location. Because the problem is the selection of needle lengths. So first thing I have done, I have calculated the length and all. Then I told her this particular needle length is not sufficient for this step. So we changed the needle to a larger length, and happily 250 ml of pus was drained. So all these are very simple and basic techniques on marking the area of needle insertion and becoming yourself comfortable when you're doing that. And in case of deeper structures, it's always, as you said, identifying the length is very important, sir. Definitely. So it can help seriously. So, that is a practical thing what we experienced in our ICU for that aspiration. Selecting the needle length and gauze both are very, very important. If you're trying to do very thick secretions, aspirations and all, the needle should be large bevel definitely for aspiration. All these things will count definitely. Forget about technologies. What we have in hand, if we do some minor changes, there will be a lot of difference. And whenever in your free time, do a scan of your own body, like you used to put the probe and, on my hand and used to see the median nerve and all. And all those things we can do in free time.
That probe, what you said, the previous probe, that artificial intelligence, and it will identify the needle. It will change the direction of the beam and identify the needle, not like that. So the mission also has to change, or the probe, same mission can be used for
same mission, same. And if you have that feature, just like how we are owning the color Doppler feature, it's like same, sir. Beam steering we have to on and adjust the direction of the beam.
Feature onto the machines lo.
Upcoming missions lo, they are actually, maybe they are available also, sir. Not maybe in US and all. Beam steering lo, that particular feature has to be turned on, sir. So if you are unable to visualize the needle, you especially in a convex surfaces like knee.
The probe is different, no? Probe, what is the cost of that probe? Is it available?
No idea, sir. Availability and all, but probe will be different, sir. Or definitely, or with the regular probe, maybe they will. These are actually termed as machine technologies, sir, not transducer upgrades. These are actually termed as machine upgrades. So maybe they will incorporate that feature in the machines itself with the same probe and all. That is my understanding of that.
Yeah.
Not sure because we are not seen or that one, but that's a wonderful feature, especially in the convex things and all. We will get a good picture, beam steering. So that is what we do manually. You know, the serrations and all, there is a very interesting story for this one. So one of my assistant professors in RMC, she has like a very good academician. She is she opted for a paper on abdominal tab blocks there. And those ultrasound guided tab blocks. So what she has done, needle visibility became very poor with the missions and all. You know how the government missions will be there. So what she has done, she has taken the needle to her home. So she has used the sewing machine at her home to drill the holes into the needle. So that is what later echogenic needles came. So most of the brains, they do actually the manual work that is being incorporated into the machines later, just like how beam steering came for heel to manual, what we do for this one. So she has actually done that. She has like increased the number of holes on the needle to make it better visible on the ultrasound. That's actually, we were awed in our PC life because of that invention by her.
Okay. Any questions from the audience? Hello? Yes, there are no questions. Thank you, Srikanth. Very nice presentation.
Okay, sir.
Next time, better we'll have a good ultrasound workshop.
Sure, sir.
We'll organize, we will plan for that. And
Okay.
thank you all for your nice presentation, and thank you all for your nice active participation. Thank you.
Thanks, Srikanth.
Thank you, sir. Thank you.
Thank you, Srikanth.
Thank you.